Hey everyone, welcome back to the NPTE podcast. This is Will Crane, your host. Thank you so much for joining me as we go through the content you need to know in order to absolutely dominate on test day. And if no one has said thank you to you today, let me be the first to say thank you for the effort you put into this. I know that it's a big job. I know that there's a lot on your plate, but let me just tell you thanks. It's a good thing you're doing, and I'm happy to be along for the ride with you. So today we'll be going through a practice question. As we go through the FSBPT content outline. As you know, we go through the entirety of the content outline from top to bottom before we start over again. Today is no different. Today we'll be talking about system interactions. So as you recall, on exam day, there are somewhere between 8 and 12 questions related to system interactions. And clearly this is going to involve lots of different systems. So like for instance, our case today is about someone who has a spinal cord injury. But then how does that relate to other systems? What will go wrong or what could go wrong in the case of, in this case, a spinal cord injury? Another good example would be like if you had traumatic brain injury or Alzheimer's disease, these neuromuscular deficits that then can yield other results. So musculoskeletal, integumentary, metabolic endocrine. There's lots of things that could be interactions with the different systems. And so I'll take you through an example here in just a moment. But before we get to our practice question, just a reminder that we have classes ongoing over at ptfinalexam.com. You can find out more about what's going on. Just head over there. Be sure to join our email list. Go to ptfinalexam.com/podcast, where you can sign up and get a free cheat sheet. We talk about what you need to know, metabolic endocrine system and otherwise. So be sure to check that out over at ptfinalexam.com/podcast. And be sure to stop by if you are going to the combined sections meeting. Come by and visit us. We, PT Final Exam, we've always got a booth going. Come by and see me over there. It's always fun to meet up with you. I've got some things we'll be giving away at the conference, so be sure to stop by. And if you're listening to this down the road, watch for us at either the Combined Sections meeting, the Student Conclaves, the Educational Leadership Conference, really any of the major conferences, we are there, so be sure to stop by and say hello. We'll be happy to have you. All right, let's go ahead and talk through our question today. As per our usual, I'll read to you the question, after which I'll give you a moment to formulate your response, and then we'll talk about the content contained therein, hopefully give you a couple of tips to make sure that this sticks for test day. All right, here we go. An 18-year-old patient with a C7 incomplete spinal cord injury is receiving physical therapy for ambulation training and muscle strengthening. At 8 months following the injury, the patient begins to develop unilateral lower extremity edema in his left leg measuring as 3+. The patient also complains of localized tenderness in the center of the posterior calf. Which of the following measures is most likely to confirm the diagnosis? So again, just some bullet points here. 18-year-old patient with a C7 incomplete spinal cord injury, receiving PT for ambulation training muscle strengthening. 8 months following the injury, the patient begins to develop unilateral lower extremity edema in the left leg, measured as a 3+ on the edema scale. Patient also complains of localized tenderness in the center of the posterior calf. Which of the following measures is most likely to confirm the diagnosis? The answers are ankle brachial index, Ottawa ankle rules, quadrant test, Wells clinical decision rule. All right, so again, ankle brachial index, Ottawa ankle rules, quadrant test, and Wells clinical decision rule. So this question, this is definitely system interactions. We've got an 18-year-old patient with an incomplete spinal cord injury, but they're having some, we'll call them integumentary changes, but really cardiovascular changes because they have unilateral lower extremity edema that's measured as a 3+ on the pitting edema scale, meaning that it's quite significant, takes upwards of 30 seconds for the pitting to return or to rebound back to normal. So clearly some significant pitting edema. And then really the kicker here is that the patient also complains of localized tenderness in the center of the posterior calf. So we have unilateral lower extremity edema, 3+, tenderness in the center of the posterior calf, plus a history of really, we'll call it paralysis, even though it's an incomplete injury, and we're doing some ambulation training and muscle strengthening. It's a relatively high, it's a cervical spinal cord injury, indicating there's likely to be some type of lower extremity weakness. Certainly something's going on. And so if at 8 months following the injury, you start to develop unilateral lower extremity edema, you start to think, all right, that's probably a deep vein thrombosis. So which of these measures is accurately assessing for a deep vein thrombosis? Well, the answer here is the Wells clinical decision rule. So it used to be that we would put a little stock in the Homan sign. Remember, Homan sign is where you'd squeeze the calf, and if it reproduced the symptoms, then that would indicate that you'd have a positive, or at least some indication of a deep vein thrombosis. However, that doesn't really have great sensitivity or specificity, leading us to, okay, we need a better tool. So the Wells clinical decision rule, or the Wells criteria, it's a list of, about 8 items that are, if they are present, if more than 2 of them are present, then it makes it very likely that there's a DVT. So for instance, in our case, we have recent paralysis, paresis, or immobilization of the lower extremity. We have localized tenderness in the center of the posterior calf, lower extremity swelling, unilateral calf swelling, pitting edema. Really, we have about 4 points on the Wells criteria, with if there was an alternative diagnosis that was likely, so for instance, cellulitis, or like a muscle strain, or even lymphedema, then that would make it obviously less likely, because there's a plausible other diagnosis that could cause this. But in this case, pretty clearly, deep vein thrombosis is the most likely cause here. So then if we look at the other answer options, the ankle brachial index, as you know, that is a test for peripheral arterial disease, where you're testing blood pressures in the arm and the leg. So the ankle brachial index, so you calculate it just the way it's named, ankle brachial index. So the ankle systolic blood pressure to the brachial systolic blood pressure, so the foot to the hand, systolic blood pressure. That's how you calculate that index. It should be close to 1. If it's not, then it tells you something's out of whack. The Ottawa ankle rules, this would be in the case that you suspected some type of ankle fracture. Again, we have nothing in the history that would indicate that we have some type of ankle fracture. And really the pain and tenderness, that's localized tenderness in the center of the posterior calf, that's very unlikely to be an ankle sprain or even an ankle break. And then finally, the last one is the quadrant test. This is the outlier. The quadrant test is a lumbar spine test where you have the patient stand and you test, in a sense, each quadrant, trying to put them into extension and side bending in order to see if you can reproduce any type of neurological symptoms. So in the case of like a herniated disc, well, more likely in the case of stenosis, sorry, not herniated disc, but in stenosis, the quadrant test is really just exacerbating stenosis. So if you had neurological signs from stenosis, that would be a sign that you'd probably use the quadrant test to rule that in or out with the lumbar spine. So all told, again, we see that the patient who has a spinal cord injury, they are at a high risk of developing deep vein thromboses. And so therefore, you'd want to be on a very keen lookout for that. I can guarantee a couple of questions on the test related to DVTs just because it's a safety issue. So what should you do in the case that you do encounter someone who has a DVT? Well, certainly you'd want to cease treatment. Now, it's not a 911 call. I mean, it is unlikely they're going to, if it does break loose and hit the lungs as a pulmonary embolism, then that would be a life-threatening case. But if it has not done that, I like to say I just bubble wrap the patient, take very good care of them, make what I call an expeditious referral, which usually involves a phone call saying, hey, doc, I've got a patient who they have all the signs on the Wells criteria for DVT. I recommend they get further workup. And usually the doc will say, okay, I just send them straight to the ultrasound or say straight to imaging, where they can get ultrasonography, where they can then determine whether or not there's some DVT present and therefore continue with either some type of anticoagulation or clot buster medication. And you'd want to get clearance from the doc before continuing with your care, just because the likelihood of it breaking loose during therapy is significant and causing a pulmonary embolism. And so therefore you just want to take really good care of it. Take really good care of the patient, and you'll find that's your best bet. So therefore, the bottom line here is the Wells clinical decision rule. And again, there's about 8 points on the Wells clinical decision rules, or the Wells criteria. I'll just list them out real quick here as you're listening. So an active cancer diagnosis, paralysis or paresis, bedridden for more than 3 days or a major surgery, localized tenderness in the center of the posterior calf, lower extremity swelling, unilateral calf swelling, pitting edema, collateral superficial vein or observance, I should say, of collateral superficial veins, meaning the deep veins are blocked, so the collateral superficial veins are being used, previously documented DVT, And then you subtract 2 points if there's any alternative diagnosis likely. So in the case that you had like an ankle sprain or some type of postoperative swelling. In any case, that is the Wells clinical decision rule, and it's very helpful for determining whether or not a person is likely to have a DVT or not. So there you go. All right. Well, with that, we'll bring this session to a conclusion. As always, much appreciated. I appreciate you spending the time with me. If you haven't, be sure to leave us a 5-star review over on wherever it is you listen to podcasts, Google Play, iTunes. It really helps us get through the algorithms, get the word out about PT Final Exam, and I'd really, really appreciate it. So have a fabulous day. Take good care of yourself. Happy studying. I'll catch you in the next episode. Thanks.